to Terry Hewlett with the Colorado Hospital Association to introduce our speaker.
Thank you, Sarah. It's my pleasure, mine and Sarah's and CHA's, to introduce Dr. Rita Olans, Doctor of Nursing Practice, an advanced practice RN board certified, and also an assistant professor at the Massachusetts General Hospital Institute of Health Professions in Boston, Massachusetts. Rita has practiced as a nurse and nurse practitioner for 40 years in pediatrics, school-based community health, and international public health. She is currently a pediatric nurse practitioner hospitalist in an acute rehabilitation hospital. Rita's doctoral capstone was the role of the nurse in antimicrobial stewardship. She has published on the role of nurses in antimicrobial stewardship in the Journal of Continuing Education in Nursing and Clinical Infectious Diseases. She is a consultant to the National Quality Forum's 2-year initiative on antimicrobial stewardship and a contributor to the Antimicrobial Stewardship in Acute Care, a practical playbook that was published in May of 2016 by the Centers for Disease Control and Prevention. She's also represented the American Nurses Association in the Pew Charitable Trust's Antibiotic Resistance project and was an invited speaker at the annual conference of the Association for Professionals in Infection Control and Epidemiology in June of 2016. Her recent webinar, Antimicrobial Stewardship in HIV/AIDS Care, was produced by the Hope Conference for Nursing. Upcoming invited presentations on antimicrobial stewardship include the Massachusetts chapter of the National Association of Pediatric Nurse Practitioners and the annual Infectious Diseases Society of America's ID Week in October of 2016. Rita is a leader in the American Nurses Association and CDC's ongoing working group on how nurses will position themselves in antimicrobial stewardship activities in the U.S. So please join me in welcoming Dr. Rita Olans. It's all yours, Rita.
Oh, thank you, Terry. That was a really generous introduction. I'm really glad to be with you today and to share my passion about antimicrobial stewardship. I just want to tell you at this point, I have no financial conflicts. Nurses generally don't. Sorry I didn't get that into a slide. If we could just go with the first slide. There we go. Okay, thanks. Let's just review these learning objectives. We're going to recognize the scope of antimicrobial resistance in hospitals, how we as healthcare professionals are evolving in our antibiotics use, and understand how nurses are already performing antimicrobial stewardship activities. And by the time we finish with this webinar in about 40 minutes, we should be able to identify 3 areas where nurses can increase their skill sets to enhance antimicrobial stewardship performance in their hospitals. Thank you. Okay, this is a map of where we're going to go over the next 40 minutes. What is it? Why now? Why nursing? Where we are now and where we're heading. Okay. So, what is antimicrobial stewardship? Well, it's the same thing as antibiotic stewardship, so the names get confused from time to time. You can either call it antibiotic stewardship, which means we're talking about just bacteria, or we can talk about antimicrobial stewardship, which is more inclusive, and that means we're talking about bacteria, viruses, and fungi. Next slide, please. Okay, so here is a definition that was crafted in 2011 between a combined task force between the European Union and the United States. This growing global threat of antimicrobial resistance was recognized in 2009 between the U.S. and EU in a summit, which concluded with a declaration that called for the establishment of a transatlantic task force on the urgent matter of antimicrobial resistance. And they focused on 3 key areas: the appropriate use of antimicrobial drugs in medicine and in veterinary communities, prevention of both healthcare and community-associated drug-resistant infections, and strategies for improving the pipeline of new antimicrobial drugs, best addressed by the intensified cooperation between the U.S. and the EU. But today we're going to be limiting our talk to just number 1 and 2 key areas: the appropriate use and the prevention of resistance. Next slide, please. Okay. These are stewardship goals. Let me give you a minute to read these. They were developed about 2 years after that transatlantic summit, and these came out in 2011. So the goals of stewardship are really to prevent or slow the emergence of antimicrobial resistance, optimize selection, reduce adverse events, and reduce morbidity and mortality. Also length of hospitalization and healthcare costs. Next slide, please. Okay, I am from the East Coast, but I do know where Colorado is. So let's see. This was a map that was put out in 2014 with the percentage of hospitals that had stewardship programs. I would bet you that Colorado, with the changes that the Colorado Hospital Association have implemented over the last 2 years, will move Colorado from approximately 1/3 of hospitals with stewardship programs to over half of hospitals now having stewardship programs. The national goal will be to have 100% by 2020. But what you're not seeing on this slide, which is a CDC slide, by the way, it says Get Smart on it. That's a CDC program in antimicrobial stewardship, prevention, and of resistance. Well, what's not evident from the slide is how much nurses can contribute to these efforts today. Stewardship teams are led by infectious disease doctors or pharmacists, traditionally. There are over 800,000 physicians in the U.S. About 8,000 of them are infectious disease specialists, and we have about 300,000 pharmacists. But that pales in comparison with the 3.1 million nurses. So let's go to the next slide. Thank you. So why are we talking about this now? Next slide, please. Resistance. It's all about resistance. The driving force behind all changes in antibiotics use is the explosion or the widespread increase in antibiotic resistance. Slide, please. Thank you. In World War II, antibiotics, this is a picture with that. Can you imagine? We can show it down in 4 hours. It was, and antibiotics came out in force in World War II, and they were considered nearly miraculous. And at that time, the understanding was there was no downside. It was all benefit with no consequences. And it was no wonder that they thought these were miracle drugs. Next slide, please. I am sure all these terms are familiar to you. They're the consequences of the use and overuse of antibiotics in medical and agricultural settings, as well as the response to the public's demand for antibiotics. This is why resistant organisms have become ever more prevalent and problematic worldwide and in Colorado. Next slide, please. In response to the pressures of the economic reality that antibiotics were becoming resistant, the pharmaceutical industry shifted its research investments into newer products, other types of medications that wouldn't become resistant. That wasn't the antibiotics. This slide illustrates the reality of what we're facing as far as new drugs for our superbugs. Next slide. drying up of the pharmaceutical research pipeline for new and effective antibiotics, we have arrived into the era of bad bugs and no drugs. This was actually the cover of Clinical Infectious Diseases in 2004. The infectious disease community has been aware of this impending crisis for some time and has been calling on politicians, industry, anybody that would listen as to the growing resistance problem we are having today. Next slide. Antibiotic resistance. Here are some of the numbers of infections per year. Cost includes the cost of antibiotics plus increased length of stay. But if you add lost wages and decreased productivity from absence from work or the death of someone by infection, the cost is actually closer to $35 billion a year due to antibiotic resistance. The CDC is calling this a public, oops, can you go back just a hair?
Yep.
Thanks. The CDC is calling this a public health crisis, and the WHO, the World Health Organization, calls this a major threat to human health, and even the Department of Defense is calling this a threat to national security. Thanks, Sarah. Can you forward the next slide? Sadly, medicine didn't learn the lessons of the last 7 decades of antibiotic miracleisms. And these are the numbers that we have. Over 50% of inpatients will receive an antibiotic, yet only about 1/3 of those will be necessary. Okay, this is an organizational chart from the Antimicrobial Stewardship program at the University of Pennsylvania Hospital. This was published in 2006. The term antimicrobial stewardship, though, was only found in a medical dictionary. The first year it was found was 2010. The CDC came out with recommendations for states to encourage antimicrobial stewardship programs in 2011. Next slide. Let's see if this is going to work. Sarah, could you just keep clicking while I talk?
Sure, I'll try.
If this is going to work. Okay, thanks. Just keep clicking. Okay, so this is the model that I propose. Why should this model of antimicrobial stewardship with the nurse at the center be used rather than the existing Pennsylvania, University of Pennsylvania model we just looked at? It's because nurses are at the hub of communication among all the various disciplines involved in antimicrobial stewardship. Nurses facilitate operational efficiency and coordinate bedside patient care. Patient safety, as outlined by the Joint Commission, is part of nursing care. Interdisciplinary collaboration is stressed by the Institute of Medicine in their 2010 report. And the public health education has always been recognized as the nurse's responsibility. And basically, this is how stewardship happens in real life with communication. Next slide, please. So why nursing? Because we're already doing it. Okay, let's walk through this. I'm going to walk you through a typical patient hospitalization in 3 parts. We're going to start with the admission. We're going to go into the clinical progress of the patient, and then we'll talk about discharge at the end. A patient arrives at the hospital. Let's say they arrive in sepsis. Antibiotics are ordered by the physician, the NP, or the PA. The nurse receives the orders in the emergency room, reviews the dosing and the time for accuracy, checks for allergy, administers, and records the antibiotics. These are all stewardship type activities. But before the antibiotics are given, the nurse obtains the cultures. There we go. The nurse obtains the cultures and sends the cultures to the microbiology lab before the antibiotics are started. Next slide. Okay. Let's talk a little bit more about this allergies history. The nurse performs medication reconciliation and records this in the medical record. And she also, or he also, takes an allergies history. Can you forward the next slide? But is it really a penicillin allergy? So people will oftentimes tell you they have an allergy to penicillin. But look at the bottom of this slide. 10% of the population reports a penicillin allergy history, but less than 1% of the entire population is truly allergic to penicillin. So what does that play out to be? That means 9+% of our patients in the United States are losing this very important, very efficient, narrow-spectrum antibiotic and are instead being given an alternative that may be more expensive, be broader in spectrum, and contribute to resistance now or in the future. Next slide, please. Okay, we're going to get back to the patient has now been moved out of admissions or the emergency room, and they're now up on the floor. So, okay, so now we have the patient up on that unit, and the progress continues to be monitored by the nurse throughout the hospitalization, 24/7. The antibiotics have been ordered and started prior to the lab results coming back, so the nurse continues to monitor for lab results and continues his or her communication to the physician, the NCRPA. Not only is the microlab reporting out important information about the offending organism, but other laboratories are processing information such as renal function, drug levels, such as with vancomycin. The patient's on the antibiotic and the nurse is monitoring progress. Excuse me. Is there an adverse event? If so, the nurse is reporting it. Antibiotics orders are reviewed. Are there any changes based on the patient's clinical status? There is a bug-drug mismatch. The nurse is reporting this back to the physician or to the pharmacist. Okay? Or do we have a super infection going on, or do we have big resistance? The nurse monitors the change in the patient's response and initiates appropriate changes in isolation precautions. Okay, so we're now getting this patient out of the hospital. Good news. We want to get that IV out to get the patient out of the hospital. Who knows better than the nurse that the patient is taking food or drink by mouth and can be switched off of that IV into the oral antibiotics? The nurse does. And who is a major contributor to the decision about the length of stay? The nurse in concert with the case manager. The patient is ready to be discharged either to home or to a transitional facility, such as a rehab or a skilled nursing facility or a nursing home. Now, the nurse communicates the patient's diagnosis, management, and medications in a report to the facilities, either verbally, written, or both, and also will be educating the patient and the family about the medications and, as such, the antibiotics. Nurses are actually in the best position to advocate and teach about medications and do the patient teaching at the end of the hospitalization. The Gallup poll is holding us as the most trusted profession. We are well above some of our colleagues in the healthcare field. So, okay, let's shift gears now. Where are we? Now we're going to be looking big again. We're going to be looking at us as a country. So let's take this broad. Thank you. Okay, we now have a national action plan for combating antibiotic resistance. This plan came out with a big meeting at the White House in March of 2015. Currently, the only available approach to the resistance crisis is antimicrobial stewardship. And stewardship is actually the husbanding of our currently available pharmacologic, microbiologic, and clinical resources. On the left-hand side of your screen is the Presidential National Action Plan. And on the right side is a representative publication on antimicrobial stewardship. It's coming out in everyone's literature these days and in the popular press. And there are over 1,000 articles addressing stewardship to date in all specialties in medicine. The National Action Plan is targeting inpatient hospitals, but efforts are underway to bring long-term care facilities and outpatient settings into the National Action Plan. Where are we heading in the future? Where are we going? Quality and regulatory agencies such as the CDC, in concert with the National Quality Forum, are creating easy-to-follow guidelines with examples of how to implement stewardship programs. The Agency for Healthcare Research and Quality, also known as AHRQ, is putting out requests for proposals to fund incubator-type pilots to try out different strategies in various settings for stewardship. And the Joint Commission is rolling out new guidelines for assessing hospitals in their stewardship activities. And private foundations, such as the Pew Charitable Trust, are supporting research with funding to address how these programs can be implemented in various settings. Right now, we have a big effort underway with critical access hospitals, many of which are in Colorado. There are but a few governmental, regulatory, and private efforts that are in progress towards the decreasing and slowing of the progression of resistance of antimicrobials. These efforts have been going on for a while, as I described earlier, but it's only been recently that the traditional antimicrobial stewardship programs have begun to recognize nurses. As mentioned earlier, we are the largest profession in the healthcare industry, and we are with the patients 24/7 with our 3.1 million nurses versus our 800,000 practicing doctors. Next slide. But how do we as nurses contribute to stewardship? Earlier slides alluded to this when we went through the admission, the inpatient stay, and the discharge roles that we as nurses play in the life cycle of the patient's hospitalization. Our nurse educators in hospitals and in nursing schools can help us to practice to the fullest extent of our education and our role. Such teaching could include how to take an in-depth allergy history, when to ask the prescribing physician, NP or PA, if the medication needs to be changed after the results come back, or informing the prescriber that the patient may be switched from an IV to an oral antibiotic. These are but 3 ways we can contribute as nurses. This is a lovely picture of the AMA along with the CDC, and this is a picture of a working group that convened in Washington this summer in July. And if you look very closely, the third person on the left is your very own Candace Allen. And she was right there in Washington, D.C., contributing to the national nursing efforts in stewardship. In the middle is obviously a gentleman in a uniform that was from CDC. That's Arjun Srinivasan. And if you want to see a picture of me, I'm standing right next to him, and I'm wearing gray with a little red necklace. Thank you. Okay, next slide. Okay, we're getting close to the end here, so let's sum up why we were not considered part of the initial efforts in stewardship. Partly, it was because we were not seen as prescribers. Nursing wasn't recognized by the non-nursing community as contributors. But the other piece to it is that we didn't recognize it ourselves. Are we stewards of antimicrobials? Yes. Let's finish this afternoon with the definition of stewardship. Stewardship is the conducting, supervising, or managing of something, especially the careful and responsible management of something entrusted into one's care. I think this describes nursing beautifully. Good nursing is good stewardship, and a good antimicrobial stewardship is good nursing. And our last slide. What can the future bring? In order to accomplish the goals of antimicrobial stewardship, we need not only to educate all healthcare professionals, but also the public at large about the problems of antibiotic resistance. We also need synergistic collaboration and multidisciplinary communication in the processes of antimicrobial stewardship. To succeed in an era where widespread antibiotic resistance exists, we must change our national attitudes concerning antibiotics, and we as nurses must play an important role in that change. Thank you so much for your interest in today's webinar. I believe we do have time for questions. Is that right?
Oh yes, we have plenty of time for questions. So again, the lines are open, so if anyone would like to chime in and contribute to a discussion or ask a question of Rita, again, we have plenty of time, or you can type a question into the chat box or raise your hand and we'll get to you.
What's the perception of, for those of you that are on the line, nursing as good stewards of antimicrobial stewardship? Is this something that you see moving forward with in terms of your bedside nursing role?
We've got a lot of folks on the line. Somebody's going to chime in, or I'm going to start calling on people. I can see who's on.
Terry, one point, this is Rita. One point that was brought up in Washington was that oftentimes nurses are not invited into these kinds of committees or these kinds of activities. They need to invite themselves in. And when they come in, they have really good ideas. I mean, it's being recognized by the CDC right now, and it's also being recognized by infectious disease specialists who are trying to figure out how to keep these programs going.
Right. And I think that was an eye-opener for me, having the opportunity to go to some of these meetings in D.C. and really see how the focus is turning a little bit to really focus on nursing's role in antimicrobial stewardship, and it goes back to some of what you shared in terms of so much of it is already being done by nursing, and I don't think that we as bedside nurses, at least when I was at the bedside, really didn't understand that I really did have the ability to be a good steward and have impact in the outcome of that patient specific to antibiotics or antimicrobials.
And the main point to this is Rita again. The main point is that this is not extra work. Nurses are not doing extra work by their contributions and to stewardship. They're actually just doing the job.
Right.
Rita, this is Mark Meyer in Cortez.
Hi, Mark.
How are you doing? Hey, I have a question. Do you think the nursing programs around the country will be adding this to general nursing education, or will it be just nurse practitioner programs like yours that will be adding it, or how do you think that will work in? I know pharmacy schools are starting to add some discussion about stewardship, not a lot, but how's that going to play out?
Mark, it's really interesting you should ask that question because there's an RFP out right now looking for innovative ways to broaden stewardship programs. And one of the ways to do this is to find out what is actually going on in the nursing schools and to start, we need to get some baseline data to see what they're doing. And my focus is really in the largest body of healthcare providers, which are the RNs. Although I work as an NP, it's really the RNs that are doing the bedside care and the heavy lifting when it comes to their observations in stewardship. So I think the emphasis needs to go inside the RN programs. And I'm working with a couple of people right now trying to collect some data on that and see if we can start influencing how microbiology and pharmacology and bedside nursing are integrated.
How do you think that will fit into the two-year nursing programs?
Well, I think it can be woven easily into those programs by just reminding while people are in the clinical settings and in the classroom and weaving it through several courses. By the time you get to the end, you know what the word means, which is a big problem. People don't know what antimicrobial stewardship is. And they'll see themselves as participants because they understand what it is and they'll understand how they can support it. I think two-year programs is a great place for it. We have a lot of nurses coming out of two-year programs.
And we've added it to our nursing students here in the hospital. They get to spend several hours with me talking about stewardship while they're here.
Wonderful. You know, pharmacists have been some of my best friends in stewardship research. I'm actually count you among them, but I'm working with David Ha out in California and with Christy Cooper, trying to figure out how we can get the conversation going between nurses and pharmacists. Nurses are very comfortable talking to pharmacists. That's been my experience, and that's what other nurses tell me. And that is a great way for nurses to learn stewardship better. Good afternoon. My name is Kathleen. I'm a nurse at Swedish in the critical care unit. And thank you so much for this webinar. It's very enlightening and very informative. So thank you for the information. We do rounds on our CCU patients every day. And the bedside nurse is responsible to know when the Foley was put in, when the central lines were placed. So we are good stewards of that. However, when it comes to antibiotics, oftentimes that's deferred to pharmacy. So I think it's important for the nurses to take it upon themselves to be good stewards, obviously, of antibiotics and know when were the antibiotics started and were they the appropriate ones. Thank you. You've hit on a topic that's being researched right now in California. They started nursing rounds and they gave the nurses specific questions to ask about antibiotic use, such as when was the antibiotic started, did the cultures come back yet, is somebody aware that the cultures are back and that the patient is still on these multiple antibiotics? And do the patients need to be on IV antibiotics, or are they now keeping food by mouth or food or drink by mouth? And they just added these questions into their nursing rounds, and these are promoting better use of antibiotics. The antibiotic use is starting to go down in the 2 months that they instituted this, and consults to infectious disease specialists are being initiated as a result of the nurses asking these questions. So it is so timely that you ask that question. If just a couple of questions could be added, they don't need to go to the doctors, they could go to the pharmacists and ask these questions. Because pharmacists are playing a critical role in antimicrobial stewardship.
Absolutely.
But the nurse should be aware of why the patient's on that antibiotic. There's a webinar tomorrow. CDC is putting out a webinar on timeouts. It's a concept that every 2 days you reevaluate whether or not that patient needs to be on that antibiotic. And I don't want to go into this in too great detail, and Mark could speak to this better than I can, but the guidelines on the length of the duration of an antibiotic is changing. And there are reasons why we have put people on 5 days or 7 days or 10 days of antibiotics, and those are all being looked at right now. So pharmacists can really help inform us as to duration. And it has a lot to do with the level of research we have right now, but also the patient's clinical status. And physicians are being taught right now to re-examine every 2 days their antibiotic prescriptions or dosing.
Oh, I thought that's a good one.
I know.
Excellent
Mark,
points,
are you
Rita.
familiar with that?
Oh, does the doctor remember the road?
Hi, if you have background noise, please make sure you mute your phone. Sorry.
Yeah, I would agree with that, Rita. I think we're looking at, I know with the UTI project we have, we went to, in the nursing home, we went to 3 days of initial therapy, depending on what they have, and then it was 5 to 7 days maximum therapy. I believe that's what we did in the CHA hospital project. And I've been doing a dental program too, and it's we're looking like I'm going to be telling dentists to use 3 days of therapy and reevaluate. And I think you see one of the problems we have too is the difference on antibiotic timeouts is the difference in time. Even some hospitals get it at 24 hours. Some hospitals we're finding out in these rural areas might get it 5 days later and the patient may have gone home. So that's going to be an issue that we have to tackle somehow too. So.
Yeah, I agree. There are reasons why this is so complicated.
And why it needs to be a
answer.
Yeah, and why I think that speaks to why it needs to be a team effort with those key people, nursing, pharmacy, physicians, driving the work and everybody being on the same page.
And if you guys need details about that webinar, you can always email us. We just sent it out in a newsletter for collaborative hospitals today. But if you are not in our Antimicrobial Stewardship Collaborative and would like that information, we have it. Is there an Ellen Mixer on the phone? I see you have a question and I am not being able to pull it up right now.
Oh, yeah, that's me.
What's your
Hello?
what's your question?
Well, I was just wondering, I notice all the time we're talking about switching patients to oral antibiotics, and I'm a nurse on the floor, and I notice all the time it's constantly IV antibiotics. And I just was more curious as to if we could go into more depth on the advantages of oral versus IV antibiotics and why it's always immediately IV antibiotics when it could be possibly PO?
You could send them home.
Let's get Mark to answer that question.
Yeah, I was thinking the same thing, Rita. Mark?
Well, I mean, some antibiotics don't have good oral blood levels. I mean, if you're talking fluoroquinolones, which we know we have really a mandate not to use as often now since May when the FDA sent that out, they have a bioavailability of 95% or plus. So there's not a lot of difference between using IV fluoroquinolone and PO fluoroquinolone. But when somebody comes in and they're sick, most of the oral products don't have a blood level high enough to get you there quickly. And I think the whole idea behind sepsis push, surge push, and other thing is to get an antibiotic with a good blood level, dosed appropriately, so you get the right, the right peaks and the right kill times and stuff like that for at least a couple days, and then you de-escalate once you get the sensitivity back to, if you have one, to a narrowest spectrum antibiotic you can use that still covers that patient. At that time, that could be oral. That's a great time to do that. But that first 24 to 72 hours, if they're hospitalized, they're probably sick enough they need IV antibiotics in general.
Antibiotics, yeah.
That sort of justifies their stay. I mean, if you're admitting them to give them PO meds, I mean, do we really need to admit those patients in the first place? Probably the question you should ask. I think in the rural communities of smaller hospitals with average length of stay 3 days, your de-escalation from IV to PO happens all as they go out the door. I think in a larger hospital, you may see the de-escalation occur from a broad spectrum to a narrow spectrum IV and then to PO a little bit later, right before they're ready to go home. I think that would be a more scenario that you see more often. I don't know if that answers your question, but that's probably the reason.
No, that helps a lot.
And there are also, so this is Rita, there's also some times when you need to have IV medication because of where the infection is. Let's say it's in the bone. If it's in the bone, very often IV antibiotics are used rather than oral antibiotics. Mark, can you explain that, why that is the case too?
Well, you don't get good penetration into the bone tissue a lot of times for some PO meds. If you're talking about osteo, you're talking about somebody that's immunocompromised, you really have to look at your alternatives, and it becomes different than just a normal patient. But osteos tend to be long, 6 weeks of therapy, that type of thing. And that generally has to be IV to get the good penetration we need to into the tissue to get that.
Good question.
Yeah.
Any other questions from our audience? I know we have a pretty good mix of folks on the line. I think we have some educators, lots of nursing staff, some pharmacists. So we have a pretty good range of folks that might have some good questions. I have one real quick, actually. Rita, and this is kind of open for discussion if anyone else has advice on this too. For like our educators and our antimicrobial stewardship team members and nurses who haven't necessarily been involved in stewardship, what's a good kind of starting step to get nursing involved in antimicrobial stewardship? Obviously, if people on their line, that's probably a good step. But what would the next step be?
Well, I did not pay you to say this, right?
I don't know. Would you like to?
I could. There's actually 2 articles that I would refer you to. One is in the Journal of Continuing Education and Nursing. This was an article that was written for was a research study on of nurse educators in a community hospital, and they were asked they were asked if they understood what they knew about antimicrobial stewardship, and they didn't know anything. And these were nurse educators, and they were really smart people, but they had never come across the term. So as the author of this article, I will disclose, I was the author of this research project. I gave them a 4-hour program by a pharmacist, an infectious disease specialist, a microbiology manager, microbiology lab manager, and myself as a nurse, a 4-hour presentation on antimicrobial stewardship. And then we asked the nurses, the nurse educators, please tell us what you think nurses need to know about antimicrobial stewardship. And they gave a list of about 10 different things, such as they need to know the difference between colonization and infection. They need to know what a gram stain means. They need to know the life cycle of the microbiology lab so they know when laboratory results are coming out. But the biggest surprise to me when doing this study was that the nurses described one of the biggest barriers to their doing stewardship or understanding stewardship was that they were afraid to ask. They were afraid to ask the physicians.
Right.
And the point of the rest of my work after I heard that answer was to say, there is no reason to be afraid to ask because you are doing such an important part of taking care of that patient and you're contributing without realizing it. So the Journal of Continuing Education in Nursing, June of 2015 is one place to start. And then there's also a charge in Clinical Infectious Diseases in January 2016. And that describes all of the activities that nurses are doing. And the purpose of that article was to tell the infectious disease community all the things, the doctors, all the things that the nurses are already doing to contribute to stewardship, so as to invite them in to these conversations, to invite them into rounds, to invite them onto stewardship committees. So you can start with education in the Journal of Continuing Education in Nursing, and you can talk about different roles. Much of what I've said today is in that second article in Clinical Infectious Diseases. So those would be two places where I would start. Or I would get on the internet and search out and see if there's more coming out. This is really just beginning to hit the big time.
Right.
As far as nurses becoming involved in stewardship.
Right. And the CDC's really kind of taken a focus on this in terms of helping nursing understand really what their role is and then working with nursing to try and move it forward.
Right. They are very interested in what they have learned about how nurses can contribute to stewardship, so much so that there's actually some talks going on between the opiate community of the CDC, people that are working on opioids and opioid addiction. And they've been talking to the people that work on antimicrobial stewardship and saying, how do we get the nurses involved? Because we know from CLABSI and CAUDI that once nurses were involved in solving these hospital-acquired infections, once they took on the responsibility, the hospital-acquired infection rates went down dramatically.
Do any of our... Sorry, we're getting some background noise from somebody, so please make sure you mute your phone. Do any of our nurses or educators have questions about that, questions or concerns, or need any more information? If anyone thinks of anything after the fact, you guys are always more than welcome to email us, and we'll get back to you as soon as possible, because I know it's a lot to take in and to kind of process, so we want to make sure that we get all your questions answered.
Yeah. And I think the big thing from Sarah and I is to just remind you all that we are here to help. And if, as you digest some of this and you think about it, if there's anything that we can do in terms of education, journal clubs, webinars, we are here to do whatever.
Mm-hmm. All right. Any last minute questions or thoughts from the group before we wrap up? Rita, any parting thoughts?
Thank you, Colorado. You are a model of best practice. What you're doing there at the Colorado Hospital Association is something that's being looked at other hospitals, and so not other hospitals, other states. So congratulations on the good work you're doing. Keep it up.
Thank you. And I think from Sarah and I and CHA, we just want to thank all of the hospitals that do this work. We realize that you guys are the ones that put the effort into it and make the improvements. And so we thank you on behalf of the whole state of Colorado and the patients that you care for.
Absolutely. With that, I think we will go ahead and close up the webinar. Again, if you guys have any questions, please let us know. We'll be sending out, again, the presentation and evaluation. We also will be posting this presentation on YouTube, so if you have anyone in your facility or anyone you know that would like to listen to it, we'll send out the link for that. And we have some of these articles that Rita was talking about, so we'll be sure to send out everything that we can to help you guys succeed in this. We hope you have a wonderful Thursday, and again, let us know if you have any questions. Thank you.
Thank you, Rita, and thank you everyone who joined us.